This is Brian Wormers recording a lecture on malnutrition for the Medical Surgical Nursing course. Here are your learning objectives. So nutritional standards, most of you have heard of this all the way through elementary school, middle school to high school. We're currently using MyPlate to look at those portion sizes as well as how much of each food group you're supposed to have. You can also look at dietary guidelines. You can look at the cultural awareness and see how different cultural groups interact, and also have some geriatric considerations about what they might choose to eat, what they're able to eat, etc., etc. So some of our nutritional assessment may include a patient history. Do they have increased metabolic needs related to their heart, to their lungs, to alcohol abuse, etc.? What can they do? What's their ADLs and what's their exercise plan? Are they burning lots of calories or are they not? What can they eat? What can't they eat? Any recent changes with that? Do they have dentures? Do they have any chewing or swallowing problems? Are they on any medications that stimulate their appetite, such as periactin or Megace, or any supplemental things such as multivitamins, zinc, iron? Any meds that might hamper their ability or their appetite? So assessment-wise, other things that we can look at would be inspection. How do they look? What's their general appearance? What's their height? What's their weight? What's their usual eating? Do they have the ability to chew, swallow? We can look at anthropometric measurements such as height, weight, BMI, skin fold measurements. We can look at clinical manifestations. How do they look? Is their hair dry? Is their skin flaky? Are their nails pitted? All those things can give a glimpse into their nutritional status. We can do labs such as H&H, serum albumin, thyroid, cholesterol, electrolytes, and looking for all these different things. So with malnutrition, we don't see a ton of this within our United States. However, worldwide, this is a major problem. What happens that we're so concerned about with this is that, of course, you're not getting enough building blocks, so you can't heal yourself, and it really affects the liver, the heart, the lungs, the GI tract, and the immune system. So they get a wasted appearance called cachexia. They have decreased activity tolerance. They get tired. They can't burn calories, so they get cold. They get some edema. They have poor wound healing, especially if they're low on protein. And this can lead to death. Where I've seen this in the United States is related down into eating disorders such as anorexia nervosa, more commonly than bulimia, but both can cause this. There are some long-term nutritional disorders such as cancer that can cause this, kidney disease, neurological diseases. If they have, if they're both caloric deficient and they've got a protein deficiency, it's called kwashiorkor. If they're just calorie deficient, it's called marasmus. So ways that we can treat this would be total enteral nutrition. This is basically feeding them through a tube. This can either be through an NG, an NJ, or through percutaneous, so through the skin into the stomach or percutaneously into the intestine. You have to be a little careful though if they haven't been eating for a while. I've seen this with anorexia nervosa. When you start refeeding them, they can get very sick really quickly, especially with their fluid and electrolyte imbalances. They tend to get hypophosphatemia, too much mag, too much potassium, too much calcium, and that can cause arrhythmias and they can die. Some of the first noted causes of this was after the concentration camps in World War II, where some of the GIs were feeding these people that were emaciated, giving these very rich calorie foods, and then they thought they were helping them out, but they were actually causing all these shifts and actually killing these prisoners. So other concerns we have to have with refeeding would be tube misplacement. We have to make sure that that tube is in the right spot. If it goes into the lungs and we feed formula into the lungs, of course that is a bad thing. We can also do this in an IV form called parenteral nutrition. This is TPN for total parenteral nutrition. We can give it just supplemental or partial if they don't need all the calories, but basically what we're doing is we're giving them all the fluid and all the electrolytes that they need. Now, more commonly in the United States, we deal with obesity, and obesity can be broken down into overweight, which is up to 10% greater than ideal body weight. It can be obesity, which is 20% or above, and morbid obesity, which is 100% above ideal body weight. Complications of this include hypertension, hyperlipidemia, coronary artery disease, stroke, PAD, metabolic syndrome, OSA, and obesity, hypoventilation syndrome. This can also lead into depression and other mental health problems. We can have urinary incontinence, we can have cholelithiasis, we can have gout, we can have back problems, we can have osteoarthritis, and it tends to lead into decreased wound healing, which is a very important thing if you're talking about surgical. So management of this, so dietary programs, of course, you guys have heard a ton of these, whether it's paleo diet or South Beach diet or Weight Watchers or any of those other ones that are out there. Nutritional therapy is part of that. Exercise programs. One of the people that I know that was in charge of a clinic for obesity said that it's simple math. It is how many calories are you taking in versus how many calories are you burning. So we really try and like to have people increase their exercise because that will help burn out some of those calories. We can help with drug therapy to try and decrease calories absorbed as well as increase metabolism, but that's probably not as effective. We do behavioral management towards the eating and the dietary, and getting to people to realize when they're eating and why they're eating. We use complementary and alternative therapies such as acupressure, acupuncture, hypnosis, which works for some people. And then as kind of a late stage, we can use the surgical management. This can be either liposuction to pull out the fat and improve somebody's looks, or otherwise we can deal directly with bariatric surgery and doing stuff such as the gastric restrictive or gastric banding. You can see this here. Otherwise, we can do a redirective and do a malabsorption. So basically what we're doing is we're taking this, sewing this shut to the stomach, and then going right into the intestine from here. Otherwise, you can do a combination of the two. Considerations after bariatric surgery includes airway management. They might have obstructive apnea. They might have hypoperfusion. So you have to make sure that they've got a good airway. Pain management after any surgery is important. Patient and staff safety is always important when we're talking about bariatrics. Some of the equipment is not rated for heavier patients, as well as moving patients can cause injury to staff. We have to care for NG tubes because after they work on this, have a surgery on the stomach, if that falls out, it can be very difficult to place back in there without rupturing any of the sutures that the surgeon has done. We have to watch for anastomotic leaks. So basically when they correct these surgeries, they do an end-to-end. So they cut out part of the section, do an end-to-end attachment, and it can leak at that attachment site. So try and prevent any blood clots or DVTs, so we're going to be using the compression hose and heparin. We're going to do good skin assessments because mobility could be an issue. Removal of the catheter within 24 hours to try and prevent any UTIs, and get them ambulating as soon as possible for all of these reasons above. We're going to monitor the abdominal girth and just track it and trend it. Post-operatively, they're going to get some very small feedings, like 15 mils of fluid every hour. So this can be quite a change for people. And then also observe for signs of dumping syndrome, meaning that they're going to get diarrhea. Their food isn't going to process as quickly, especially if we're involving part of the intestines. This concludes this lecture. If you have any questions on it, please contact your instructor.